The series is dedicated to discussing the most pressing policy issues in South and Southeast Asia. The Colloquia is organized by the Advanced Study Institute of Asia, which is an interdisciplinary and autonomous research center affiliated with Sri Guru Gobind Singh Tricentenary University. Our research covers South and South Asia, political, economic, health, and security domains. Our products include ScienceMaker Conversations, bi-weekly newsletters like Decipher, weekly newsletter like IP Wave, and other academic publications. Now, I would like to extend my gratitude to our organizing partner, the Institute of New Economic Thinking Young Scholar Initiative. At the start of Colloquia Panel Session 1, I have made an announcement that we have prepared a working document titled No Safe Blood Lead Levels, Understanding Thresholds, Compliance, and Legal Consequences. You can see that working paper here. It's a working paper that provides an Niti? Okay. It's a working paper that provides an overview of the laws and regulations surrounding lead exposure, including the various thresholds and standards that exist. The document acknowledges that there is no safe level of lead exposure, and yet compliance with these regulations remains a significant challenge. The working paper version 1 serves as an initial document for organizations working in public health to help with their ongoing efforts to address the issue of lead poisoning in South and Southeast Asia. We hope funding organizations, monitoring organizations, and government organizations benefit from it. We have already shared it with the experts to facilitate review and suggestions that will help shape and strengthen the document further. Once we have received and incorporated the expert feedback, we plan to make the document publicly available. So, the Progress and Policy Colloquia on Addressing Lead Poisoning in South Asian Countries aims to bring together experts, stakeholders, and policymakers from different countries to discuss the current state of lead poisoning research, policy framework, and prevention strategies. This colloquia aims to serve as a platform for knowledge sharing, policy dialogue, and collective action to address the critical issue of lead poisoning. The goal is to identify gaps and limitations in existing policies, research, and to propose recommendations for strengthening the policy framework and research agenda on lead poisoning in Asia. Before we begin the panel session, let's take a moment to review the agenda. The panel session is on addressing lead poisoning in South Asia, impact, challenges, and policy solutions. It's a 90 minutes long. We have a panel of 3 speakers. Each panelist have been allocated 20 minutes to share their work. After the presentations, we'll have a 10 minutes Q&A session. We encourage participants to actively participate by asking questions to the panelists by posting their questions. To begin, I am pleased to welcome Professor Amogh Devrai, the Research Director of Asia, who will be moderating and chairing the important session. Professor Amogh is a distinguished visiting professor at JNU, served as a provost at SGT University. He is also a fellow of many prestigious learned bodies, bringing a wealth of expertise and experience to this panel session. Over to you, sir.
Thank you, Shipra. I'll be chairing and moderating, though that's a very fancy way of saying that I'll be looking at the time, because there's absolutely nothing that I will be doing or that I can add to the contribution of the 4 people who are going to be speaking after me. So Shipra has introduced the panel, which is addressing lead poisoning in South Asia, impact, challenges, and policy solutions. We wrapped up our keynote, we wrapped up our panel 1. And the first panel had a lot of participation from people in India, but also our neighboring countries of Nepal, Bangladesh, and 1 or 2 participations from South and Southeast Asia. But as I said, it's a webinar on demand and will be available for people to view. And I have got a lot of requests for making it available as soon as possible. Having said that, the job that now falls to me is to introduce the panel that is going to be speaking after me, and then just get the conversation started as soon as I can. So first and foremost, I extend a warm welcome to all of you. And I also extend a warm welcome to Dr. Indu Bhushan, who will be our keynote speaker for this session, followed by the panel and the panel discussion that is going to ensue. Dr. Indu Bhushan really needs no introduction, but he's a an Indian bureaucrat who served as the first chief executive officer of Ayushman Bharat, India's national healthcare coverage program. He, before he joined the Ayushman Bharat, he held various positions as Indian Administrative Services officers too in the country. He was also on deputation to the World Bank. And following that, he held various senior and strategic positions at the Asian Development Bank, based in the headquarters, Manila, in Philippines. Dr. Bhushan's contributions to the medical field have been widely recognized. In 2020, he received the prestigious Global Achievement Award from the Johns Hopkins University Alumni Association. Currently, Dr. Bhushan chairs the India Working Group on lead poisoning and leads the India Lead Elimination Action Project. It is an initiative of the Pehle India Foundation. It brings together stakeholders. They conduct research, and they also develop policy recommendations to address lead poisoning in India. And he also works very closely with Pure Health in different consulting capacities. We have Professor Howard Hu, again, somebody who doesn't really need an introduction, but it's my job to do it, so I'll have to do it. An American physician, scientist, internist, and specialist in preventive medicine and environmental health. He's the Flora L. Thornton Chair and Professor in the Department of Population and Public Health Sciences at the Keck School of Medicine, University of Southern California. Prior to joining USC, Professor Hu held several academic positions and research focusing on understanding the impact of exposure to toxic chemicals, such as heavy metals, endocrine disruptors, and carcinogens on human health, particularly during sensitive life stages. Professor Hu has led numerous epidemiological studies investigating the contribution of lead exposure, genetics, and gene-environment interactions to the development of chronic diseases in adults and impaired development in children. Professor Hu has served on various advisory boards and continues to do that. And he's received numerous awards for his contribution to the environmental epidemiology and public health. I welcome you, Professor. He'll be discussing about the early lead exposure and its lasting impacts on cognitive development and health outcomes. We have Dr. Perry Gottesfeld. He's the Executive Director of Occupational Knowledge International. It's a non-governmental organization dedicated to improving public health and environment in developing countries. Dr. Gottesfeld has been instrumental in initializing a global partnership to eliminate lead in paints, launched jointly by the World Health Organization and the United Nations Environmental Program. He also serves on the US Center for Disease Control's Advisory Committee on Childhood Lead Poisoning Prevention. Under Gottesfeld's leadership, OK International works in partnership with governments, businesses, and other NGOs to address inequalities and inequities in environmental standards, providing technical assistance, training, and certification programs. In 2014, Dr. Gottesfeld received the Social Responsibility Awards from the American Industrial Hygiene Association for his contribution to the advances made in environmental health and safety communities in need around the world. Welcome, Dr. Gottesfeld. He will be discussing the need to improve environmental and health policies in South Asia. We also have Dr. Sudha Rajagopalan. She is an epidemiologist and a program manager for the lead poisoning prevention program at the Florida Department of Health in Tallahassee. She has been involved in lead poisoning prevention since 2014. She oversees lead testing and tracking the occurrence of lead poisoning cases among children and adults across the state. As the program coordinator, she is responsible for the oversight of lead poisoning prevention and case management activities in each of the funded counties, as well as across the state. Ms. Rajagopalan has served various epidemiological capacities at the department over the last 7 years, providing data analysis and support to chronic diseases. It should have been Dr. Rajagopalan, sorry about that. And these things have extended to trying to understand different cancers and what they are responsible for. Dr. Rajagopalan will be discussing the role of epidemiology and public health in preventing lead poisoning. Having said that, my work for the conference is largely done. So thank you very much. I would like to invite Dr. Indu Bhushan to deliver his keynote address. Over to you, sir.
Thank you, Professor Amogh. Thank you for inviting me to join today's seminar, but also thank you for organizing this seminar, which is very much needed. I am really honored to be sharing the platform with some of the biggest names in the field of lead poisoning. These are the people who have done groundbreaking work and which has significantly advanced our understanding of this critical public health issue and which has led to substantial policy changes globally. In India, it is fair to say that exposure to lead and lead poisoning is an under-recognized, underappreciated, and under-responded public health problem. The issue of lead poisoning is mired in a vicious circle of policy paralysis, as there is limited policy attention to this issue. There is no systematic surveillance of the prevalence of lead poisoning. Since there is no data collection, policymakers do not know the extent of the problem. Since they do not know the extent of the problem, there is no policy attention to the issue, with almost no resources or efforts devoted to this issue. I've been speaking to many policymakers in the country and also at the state level. None of them have realized the importance of this issue. We need to break this vicious cycle. This need to stop. But addressing the issue requires our action at three fronts. First, we need to establish credible and representative data. Second, we need to develop affordable and effective technologies to tackle lead poisoning. And third, we need to formulate effective and context specific policies and governance structures. So let me take up these issues one by one, issues of data, technology, and policies. So start with, of course, we need credible and nationally representative data to underpin any response to the issue of this uh, great, uh, great importance. While there are several surveys and studies which have shown high level of lead toxicity in the population, there is no nationally representative data. Several sources have suggested that more than our half of our children have more than 5 microgram per deciliter lead levels in their blood. These studies are actually questioned by policymakers, and most of the policymakers don't believe in these studies. So we have to establish a robust system to monitor lead level both in blood and bones. This will have to also we need to pinpoint high risk areas and high risk populations, which will help in guiding our interventions. Collecting data on prevalence will be only the half the story. We also need to collect data on the sources of lead exposure. Unless we know the sources of lead exposure, it will be impossible to plan any effective response. From everyday items like spices to cosmetics to environmental factors such as air, water, and soil, the sources are diverse and they vary from place to place. Of course, many occupations also expose workers and their families, and so we have to find those as well. In addition to data on prevalence of lead poisoning and sources of lead exposure, we also need data on the impact of lead poisoning on development outcomes. Of course, this work has been done by many of the panelists which are present here, but we need to do this work in the context of India so that we can convince policymakers that this is a problem which exists and which is having a huge impact on development, which has a huge development implications, and we need to focus on this and we need to prioritize this. So we need to have data both on prevalence, sources, and impact. And now let me turn to the second part, which is technology. And since of course, data alone will not help, we need effective and affordable technology to respond to lead poisoning. We need more affordable technology for testing lead levels in blood and bones. The current technology is expensive and cannot be used for testing at scale. Similarly, we need better and cheaper technology to detect the sources of lead exposure, including items of daily consumption. Similarly, there's a need for better technology to address lead toxicity in people. Once we identify it's a problem, we need a technology to address that. And as we know, India has a large pool of technically competent professionals and very vibrant startup community, and this can help in developing these technology. I recall when COVID-19 pandemic hit the country, testing of COVID-19 was extremely expensive. Within a few months, the price is reduced by 90% with new technology. This helped not only the country but also the whole world. The same thing need to happen for lead. So again, while data and technology are important, we also need strong policies and legislations to ensure that exposure to lead is eliminated, high risk population is identified, and vulnerable populations are protected. We need to ensure that our standards for lead contaminations are world class and are strictly enforced. As a matter of fact, we already have excellent standards, but there's some important gaps as well. Informal sector, which most people, poor people interact with, are beyond the purview of current food safety standards. Similarly, there are no standards for cookware. We need to fill these gaps. Even more important thing is that we need to effectively implement the current standards. We'll need to ensure that the surveillance of blood lead levels is mainstreamed and is made part of all regular surveys. We also need to ensure that all pregnant women and school going children are tested, compulsorily tested for lead levels. We also need to ensure that our health sector providers are adequately trained in identifying the episodes of lead poisoning and promptly responding to it. Our studies have shown that health sector providers, our doctors, are also blind to problem of lead poisoning. Our hospitals, public health system, health and wellness centers will need to be adequately equipped to take on this responsibility. Let us recognize that lead poisoning is a multi-sectoral issue. While responding to lead poisoning is primarily the responsibility of the health sector, preventing the exposure and creating awareness about it are to be done by various other ministries, including ministries of mine, industry, environment, water and sanitation, chemicals, labor, education, water and child development, food processing and food safety. Therefore, we need to have a robust coordination mechanism, and it has to be a whole of a society approach. Finally, the private sector needs to play an important role. Much of the exposure to lead is mediated through private sector. An effective system for checks and balances will need to be evolved. A set of policies that provide incentives for responsible behavior and disincentives for exposing people and populations to lead will need to be instituted. Civil society will also need to play its role. As Professor Amogh Rai mentioned, we have formed an India working group to address lead poisoning, which I chair. This informal group comprises representatives from civil society, academia, international development agencies, and some government institutions. Our objective is to generate credible evidence about the challenges posed by lead poisoning for India's future, elevate its importance in policy discussions with the government, and seek to mainstream responses to lead poisoning in government programs. So, this seminar today is also going to help in terms of achieving the objective of India working group. So, tackling lead poisoning in India is a huge task, it's a formidable task, but we believe that this is entirely achievable with concerted effort and collective will. By gathering comprehensive data, leveraging innovative technologies, and implementing coherent policies across sectors, we can safeguard our children's future and unlock India's full potential. I believe the fight against lead poisoning in India is both a moral imperative and an economic necessity. It demands bold leadership, innovative solutions, and steadfast collaborations across sectors. By harnessing the power of data, technology, and policy, we can catalyze meaningful changes and ensure that no child's potential is undermined by preventable environmental hazards. Once again, I extend my heartfelt gratitude to Amogh for organizing this critical seminar. I look forward to the discussions that lie ahead and learning from the insights of some of the biggest names in this sector. Thank you again.
Thank you, Dr. Bhushan. You called the tackling of the lead challenge a moral imperative that sets the tone for this colloquia and what we are trying to address with it. And also, you gave us a three-pronged agenda for trying to tackle it in India. It's a huge problem, and also in my rush to introducing you, I might have given you an extra thing about being a consultant with Pure. I now realize that that is not the case, but every organization working in the field has access to your advice and your sagacity in the matter. Thank you for that. With this, we are now going to be opening it up to our panelists, and I would like to invite Professor Hu. Before I do that, some ground rules. So my job here today is just to kind of be the interrupter in chief. At 18-minute mark, sir, I'm going to sort of let you know that it's 18 minutes, and then you get another 2 minutes to mop it up. So 20-minute presentation. I am sorry if that would be interrupting your flow, but my job is to keep it to time. Thank you very much. With that said, over to you, sir.
Of course. Thanks so much. First, a big thanks to the Advanced Study Institute of Asia for this invitation. And those are greatly inspiring words from Indu Bhushan. They really lay out the challenge to India. So I have three reasons why I'm especially pleased to be here today to share with you some of this knowledge. One is that I've spent about 35 years studying lead toxicity and exposure, particularly in the United States, but also around the world. The second is that I had the great privilege in the year 2000 to be a Fulbright scholar in India, and I've come back every couple of years to work on the lead exposure and toxicity issue in children, working with my colleague, Dr. Kalpana Balakrishnan at Sri Ramachandra University in Chennai. But third, next slide, please, is that as a scientist, it's been greatly gratifying for me to see that our research gets translated into policy. And in the last few years, we're greatly gratified to see that UNICEF has taken up this issue because it's so important, particularly for children, and at a time where many of us were surprised to see that with the global phase out of leaded gasoline, we still have this retained and in fact increasing lead exposure problem around the world from the multiple sources of lead exposure that occur from industry, consumer products, and everything else. So I was very pleased to be a consultant for UNICEF on their report that came out, The Toxic Truth. I would encourage anybody who would like to see this visually arresting but also important document to take a look at this report that came out of UNICEF. Next slide. So my job today is to give you a scientific overview of lead toxicity. But first, I have to say that this is a distillation of hundreds of scientists who have been working on this for decades, coming from multiple different disciplines. Toxicologists, basic scientists working in the laboratory, epidemiologists, biostatisticians, health economists. And we have worked hard to extrapolate using the knowledge we have to understand the lead exposure issue around the world. Now, this map is a visual representation of what we understand are the children's average blood levels by country, estimated in 2019. And as you can see from the color coding, that the major lead exposure that we can still see is happening particularly in the global south. We're talking about South America, sub-Saharan Africa, but certainly South Asia. But even then, we still see some retained pockets of lead exposure in the middle income and high income countries. And even here in the United States, because of the use of lead plumbing in old housing and still the retention of lead paint in any house built before 1975, we still see lead poisoning, particularly in low income populations that are living in substandard housing where the lead paint is deteriorating or the lead piping gets dissolved due to the substandard quality of the drinking water. Next slide, please. Now, part of what we need to understand is why is lead so toxic? And this is an important question because what we're seeing is that even at the very lowest levels of lead that we can measure in blood, going all the way down to 1 microgram per deciliter, lead appears to be toxic. Now, why is that? Well, it turns out that lead is a so-called xenobiotic. It, unlike other metal elements like calcium or magnesium, lead has no useful purpose in the body. On the other hand, it actually mimics some of the other metal divalent cations in the body, particularly calcium. And because of that, it substitutes for calcium in some of the key enzymes throughout the body, but it is an imposter. Unlike calcium, it doesn't allow these enzymes to function properly. And some of the key functional properties is allowing for neurologic transmission. That includes the nervous transmission that occurs in our nerves and that allows our muscles to be innervated and to function, but also, of course, the brain. Now, here's a really important part of what we've learned is that even though lead exposure is not at levels at 1 microgram or 2 micrograms per deciliter to cause outright cell death, it is still enough to cause interference with some of the most sensitive growth properties of the brain. What happens? Well, when you're born, you have billions of brain cells, but by themselves, they don't allow you to think. It's all those wonderful things that happen with stimulation, with mother's love, with the visual stimulation of what happens with sight and hearing and touch that allows these neuronal cells to then form these synapses that are these connections, these networks of connections around the brain that give you thought. And what lead does is that it interferes with the very sensitive signaling that goes on to allow these synapses to occur, and also for the synaptic pruning to occur, that is the efficiency of those synaptic transmissions for those thought processes to be efficiently transmitted. So essentially, lead introduces noise so that the synaptic networks that are developed are fuzzy, and it gives you fuzzy thinking, and that's enough to start lowering the IQ and the ability of our children to excel in the classroom. Next slide. Lead is also a pro-oxidant influence where it accelerates the aging processes around the body, because aging is so much a function of oxidative damage to all these cellular processes and structures around the body. And among the most sensitive structures is the cardiovascular system. So lead amplifies the oxidative damage to the cardiovascular system so that your arteries, for instance, are less elastic. So when you're pumping blood, they start to stiffen, and that gives you hypertension, for instance, and accelerates the hardening of these arteries. Next slide. The ultimate effect is that lead decreases the ability of our children to think. It actually increases the anxiety and the inattention in children. And these two graphs give you a visual representation of the sensitivity of these systems. The graph on the left is one of the best international pooled analyses of blood lead studies in countries around the world, where on the x-axis you can see increasing blood lead levels, and on the y-axis you can see decreasing IQ. And you can see that actually the lead IQ relationship is operant all the way to the very lowest levels of blood lead, going down to 0. In fact, the slope of that relationship seems to be steeper in the first 0 to 10 micrograms that can be measured in children's blood lead system. And on the right-hand side is a study that we performed actually in India with our colleagues at the Sri Ramachandra University, where we measured blood lead and measured all these different indices of attention. And you can see at blood leads going down to 5 micrograms per deciliter and going up, we can see this dose response increase in inattention in these children, which gives them the less ability to focus on what they need to know in the classroom. Next slide. The other impact of lead, because it impacts the cardiovascular system, is that it increases the risk of adults for hypertension. Hypertension turns out to be one of the major risk factors for cardiovascular stroke, heart attacks, and death. And in this study done by my colleague Bruce Lamphere, they used the data from the National Health and Nutrition Examination Survey. This is one of the largest studies that is community representative all across the United States, to show that even at very low levels of blood lead, you can start to see increased risks of heart attack, stroke, and death because of that. And the estimate is that blood lead levels may be responsible for around 37% of the heart attacks that have been seen over the last 15 years in the United States. Why? Because of the legacy of all the lead exposure that our adults have seen in the United States for the past 30 years, even though their blood lead levels now have effectively decreased to very low levels in our country. Next slide. Now, what our research group has done is that we have developed various tools for measuring the amount of lead that's accumulated in bones. Why is that important? Well, it turns out that when you're exposed to lead, your blood lead levels come down very nicely over the next few months and years. But in fact, lead's impact lingers for a very long time, and that's best represented by how much lead is in your bones. Because what lead does is that it substitutes for calcium in the mineral structure of bones, and there it sits for decades. So measuring lead in bones, which we do with an instrument called X-ray fluorescence, it's a non-invasive measurement, sort of like the bone densitometer that's used to measure grandma's bone density, except we measure lead and calcium in bones. It turns out that the bone lead levels are a very good dosimeter, if you will, an indicator of how much lead you've been exposed to for years to decades. And when we use that to measure cumulative lead exposure over time, that turns out to be a better predictor of your risk of hypertension. And here's our study that we published in the Journal of the American Medical Association showing that even among community exposed men, not occupationally exposed men, but just men in the general community, if you happen to have bone lead levels in the top quarter compared to the lowest quarter, you will have doubled your risk of hypertension in the United States. Next slide. Now, it turns out that it's not just men, it's also in women. Here we did a study where we measured bone lead levels in nurses. These are female nurses in the United States, not an occupational group that you would think have had a lot of lead exposure, but just like any other community exposed women, they have measurable bone lead levels. Same thing. If the women turns out to have been in the top fourth of the population for bone lead levels, they will have doubled their risk of hypertension. Again, one of the major risk factors for cardiovascular stroke, heart attack, and death. Next slide. Now, why is this a phenomenon that most clinicians don't know about? Well, it turns out that everything that I've been describing with these low blood levels, under 10 micrograms per deciliter, these low levels of blood lead that then collect in bone, happen at levels that are too invisible to be seen, that are associated with no symptoms, and clinicians are basically unaware. No symptoms if your blood lead is well under 30 micrograms per deciliter, which the chart on the left shows you is the level at which we experience decreased IQ, decreased cognitive function, decreased ability to attend in class, altered mood and behavior, and even in lower fertility in adults. Now, once you get blood leads over 40, then you actually get severe symptomatic lead poisoning, and that is still seen occasionally among particularly adults and children who are exposed to very high levels of blood lead. Then you can get abdominal colic, which is this unremitting abdominal pain, severe neurologic effects like nerve palsies and wrist drop, epilepsy with seizures, and finally, at the very highest levels, you can even die from lead encephalopathy. But again, that's only seen with very high blood lead levels. Now, on the right-hand side, we introduce another problem, which is pregnancy-related lead exposure, because it turns out that lead during pregnancy crosses the placenta with no problem at all and affects the fetal nervous system development. Next slide. Here's where we have another problem, which is that these bone lead levels that collect over time get mobilized during pregnancy because the woman's skeleton is literally dissolving itself to provide calcium to the growing fetal skeletal system. And unfortunately, the lead that's in the bones that I already described goes out with the calcium, crosses the placenta, and then attacks the fetal nervous system as it's developing. That's a real problem because even if a woman, when they're pregnant, does everything she can to avoid lead exposure, she's still going to suffer from the lead that's collected in her bones from years. So the lead exposure problem is not just a problem for children and adults, but it's a problem for children as a transgenerational toxicant for the next generation. Next slide. We've documented that by measuring
Professor,
bone levels in women.
last 2 minutes.
Thank you. And finding that those bone lead levels predict lower IQ in the offspring. That is a shocker. Next slide, please. And as it turns out, if you actually try to reverse the lead exposure problems by administering the only drug that's known to remove lead from the body, that is chelating drugs. We've done this multi-center trial published in the New England Journal that showed that the chelating drugs do not improve IQ in children. Next slide. So the real answer to all of this is prevention. And the health economists have shown that as you lower IQ, you've already started to remove the earnings ability of children with an estimated $6 trillion of the global cost. And of course, for societies like India, which is working so hard to take advantage of the knowledge economy for its economic development, this is not good news. Next slide. So the bottom line is that all of us, including the health sector, as Dr. Bhushan said, need to get involved in understanding the lead exposure problem, do the surveillance that will understand what is the invisible impact of this problem on our children. Next slide. And we need the multi-sectoral leadership of this kind of problem to attack it, because the sources of lead exposure are things that the health sector cannot control. We have to understand lead's intrusion into cookware, into spices, into the batteries, and into the other places where we can prevent exposure. It is not a treatable condition. This is an invisible, silent problem that we need to prevent as the final measure and solution. Thank you very much.
Thank you, Professor Hu. That was a very enlightening presentation. It covered a lot of ground. It started with essentially the need for having an interdisciplinary focus on this, and it ended with the 5 points. But in between, it covered perhaps one of the most drastic reasons why we have to focus on it, because of all the background drivers that the blind spot, the knowledge blind spot about lead levels leads to. And this is pretty interesting, because now then it takes us to from what is happening from a clinical point of view to how do we design better policies to safeguard in the occupational spaces. And to talk about this and to present, I think your presentation is loaded, Dr. Gottesfeld. So I'm now going to invite you to deliver your remarks. Again, at 18-minute point, I'm going to come and just remind you that you have 2 minutes left. Having said that, it's over to you.
Thank you very much. It's a pleasure to present to you today, and I want to thank the organizers for not only inviting me, but for arranging this, because I do believe that it's really important to raise the awareness of this issue in India and South Asia at large. I'm going to talk about the various exposures to lead in the environment and the need to improve both the environmental and health policies to address these exposures in India and beyond. First, let me say and reiterate what you just heard from Dr. Hu, that lead is a cumulative toxin. It's stored in the body, primarily in the bone, and only slowly excreted. So that has some serious implications for how we would plan and devise policies to address this issue. It means, first of all, that there's we have to recognize that lead is coming at us from multiple sources over our lifetimes. And it is not just a single source of exposure that is consistently responsible for elevated blood lead levels across populations, across countries. And it varies by age groups and times of life and across diverse subpopulations, as we just heard, for example, with pregnant women. So we know that all of these thousands of exposures over our lifetime contribute to our body's lead burden. And these multiple sources are significant in terms of health in the long run. We also know that soil and dust are the most common way that children get exposed. mostly from hand to mouth contact by playing close to the ground. And so when we talk about soil and dust contamination, it's important to note that this comes from multiple sources as well. It comes from airborne emissions, from industrial emissions, from paint, comes from the legacy of using lead fuels, lead and gasoline, and of course, even workers who are exposed to lead on the job take this home on their clothing and their hair, on their skin, to their families. And this has been well documented. So when we look at this holistically, we realize that all of these sources must be regulated and addressed accordingly. And this is a graph showing the consumption of lead in the US back 20 years ago. And I point this out because it's probably looks the same today as it did then, both in the US, but also around the world. It would be no different if we looked at the situation in India or other countries of South Asia, where by far the largest consumption of lead goes into making lead batteries. This accounts for about 90% of global lead consumption. Of course, we have taken out of lead out of petrol over the years, and that's now just a very small issue in countries like the US that still use it for aviation, single engine aircraft. But most of the other lead is going into paints and pigments and ammunition, and of course, a little going into solder and some other uses. But this tells us that we cannot begin to tackle this problem unless we begin to address exposures from the lead battery industry. And we know that, I'm sorry, it looks like I skipped a slide, so I'm going to go back one for a second and say, although lead is one of the most studied toxicants, very few studies have actually examined the question about which of these exposures is the most significant. One exception to that was a study published by Mary Jean Brown et al. In 2022, recent study that was done in Bihar in northern India, looking at 135 children that had a mean blood lead level of 15 micrograms per deciliter in their blood. By contrast, the median exposure blood lead level to children in the US is less than 1 microgram per deciliter. So these are very highly exposed individuals. And the study investigated various sources of exposures, including their water supply, food supply, spices that were being used, the dust in their homes and soil around their homes, as well as the paint. And the findings demonstrate that, like in many other studies of this nature, that soil and dust contamination have the greatest impact on children's blood lead levels. That was no surprise. But what we also see from this study that there's no single source that could be identified by the authors as the culprit for this extremely high blood lead level in this population. And therefore, they conclude that thus a holistic approach to identify and mitigate all sources of lead exposure is needed. And I think that's an important message, not just for India, but for the region as a whole, that we can't pinpoint a single exposure of greatest importance and have to work on eliminating all such exposures. So given that the situation in terms of lead usage has not changed in other parts of the world, and we're still using actually more lead than we ever have globally, the question is then why are exposures much greater in South Asia than they are in other regions? And the answer again is fairly complex. There's certainly more occupational exposures, which means there's more opportunity for take-home exposures of the lead and dust that we talked about. But we also know that nutrition plays a significant role because those with poor nutrition absorb greater concentrations of lead that they're exposed to. And we also know that in South Asia, there's a higher proportion of children than there would be in the US or Europe. And of course, that we know that children are more susceptible, both have having greater exposures, but having greater health impacts from that exposure. And there's a lack of infrastructure for collecting used lead batteries and for recycling those batteries in the region. And this is a huge issue because, as we said, this is the largest usage of lead, but also because when we make batteries and recycle them, it's required that we melt the lead, and that process itself has some of the highest exposures that we see anywhere. And we know that lead is purposely put into paint and plastics and other products, and this is continuing to this day. Back in 2009, at the International Conference on Chemicals Management, the UN voted to eliminate all usage of lead in paint. Unfortunately, today, very few countries have actually done that. Less than a handful of countries has eliminated lead paint from both residential sources and industrial paints. And that's a key for eliminating this problem over the long run. But we also know that there's inadequate regulations on lead industries, and that's true in many countries around the world. But in South Asia in particular, the other linked fact is that there's a lack of enforcement. Even where we have regulations, there's no enforcement, and therefore these regulations are not taken very seriously by industry. So if we look at the lead battery industry, we said this is actually the, aside from ammunition, this is the only sector that's growing, and it's growing rapidly in countries around the world. And that's because lead batteries are not just in every vehicle, electric and conventional, but they're also used for backup power. And this means that they're going into solar arrays in people's homes. They're used to store energy in wind and solar power arrays. They're also used for backup power in offices and homes, and of course for cell phone towers, computers, and other important essential infrastructure. And we know that there is no practical way to fix the informal recycling that occurs in low and middle income countries around the world. This is a highly polluting and extremely common way to melt down a battery after it is no longer useful, but it's one that causes significant environmental contamination in the process. And there's no way that we could fix that problem. What we have to do is we have to shut that down. But it's not just the informal sector recycling that's a problem. The formal sector is maybe even a greater problem. And the reason is, if we look at India, for example, there are 672 registered, meaning legal, licensed, very small lead battery recycling plants. By contrast, the US has just 10. And the battery market in the US is similar in size, in rough figures, to the Indian market. So it's important that we recognize that by having so many small facilities, these cannot economically afford adequate environmental controls. And therefore, these plants have tremendous emissions to the community, and their workers are significantly poisoned from these exposures. We know that unless we begin to address this problem, it's going to cost billions of dollars to deal with the legacy of the lead contaminated soil and dust around these plants, unless we act now. But it's not just the recycling of batteries that's a problem, it's also in the manufacturing. The photo on the left was taken in 1914 and published by Alice Hamilton, who's considered the pioneer of modern occupational medicine. I personally took the photo on the right, and I assure you I was not alive in 1914. And you could see that very little has changed in some of the facilities that are currently manufacturing lead batteries around the world. And these facilities also have very high emissions to the environment, as well as these occupational exposures of concern. And we know that there are significant differences in how countries regulate lead, particularly if we look at industrial emissions and air standards. So if we compare the US, Mexico, and India, we see that the stack emissions allowed for each industrial uh, air stack in India is allowed to be 10 times greater. The concentration of lead emitted from each stack is allowed to be 10 times greater than it is in either the US or Mexico. In the case of the ambient air standard, measuring air outside of industrial facilities and in the environment at large, the Indian standard allows about 6 times greater airborne concentrations of lead than are allowed in the US. But lead regulations are out of date around the world, not just in India, but even in the US. And that's because most of these standards date back to the 1970s. And we didn't know what we know today at that point about the hazards of low-level lead exposures. And so regulations have not kept up with our knowledge of the problem. And this is having a huge impact on the health of both children and adults, as you just heard from Dr. Hugh. In India and all countries in South Asia have a need to review and develop comprehensive regulations to lower the regulatory standards for lead in air, water, food, consumer products, and in the workplace. And they also need to develop true financial penalties for non-compliance, because often we'll see that regulations are there, but there are no penalties, and there certainly is no enforcement for most of these standards in most of the global south. So we need to develop some regulatory standards to address this issue and to raise awareness of the problem. We need to put in place some very simple requirements and disclosure laws, which have very little cost to government, but can have a big impact. In countries like the US and Europe and even Mexico, there are laws that industries annually disclose their emissions of specific toxicants to the environment. And this must indicate what's going to the air, what's going to the water, and what's being taken to hazardous waste landfills. And there needs to be transparency in air monitoring. We have these standards for ambient air and stack emissions and tell industry that they have to monitor these, but there is no way that those are ever recorded, and they should be mandatorily put online by industry in real time so that we could get a better sense of the key sources of lead exposure in these countries. And we have to put in place mandatory product ingredient labels so that companies that are using lead disclose this. Even if we look at lead in paint, very, very few companies actually put this on their labels. And often we see the opposite, that they put labels on their products that there is no lead paint, when in fact there is lead in those products. We also need to have hazardous warning labels where there is lead present to warn people about those hazards. And then in the case of paint, we need to put in place third-party certification. This is a way to certify paints that don't have any added lead by having them regularly tested from the marketplace. And companies pay to participate in these programs, but the benefit they have is that they are then purchased preferably by government and large purchasers. So government can play a big role here again without any additional cost by requiring the paints that the paints they purchase, for example, are certified, or even to go further, they could require all paints being sold at a date certain contain this certification if they're going to be sold in retail outlets. This program, the Lead Safe Paint program, was started about 5 years back, and it's now taking hold in the Philippines, Sri Lanka, Bangladesh, and other countries. So this is something that is a model that's out there that can be expanded without any consideration and planning. It's there, it's been used, and industry that participate can attest to the fact that this works. And then we need to ban the production of lead chromate. Lead chromate is the most widely used lead pigment, and it's the one that goes into paints and plastics, as well as some other products. The European Union studied this chemical very extensively and determined that there are substitutes for all applications of lead chromate. And as a result, they decided to ban lead chromate from production, but also from the import and export of this product from the EU. So there is no reason that other countries shouldn't follow suit and ban this chemical that is being currently made by several manufacturers in India and others around the world. And just as a side note, it's not just the lead in this chemical that's a problem, but the chemical contains hexavalent chromium, which is a well-known carcinogen. Aside from that, we need to restrict trade in other lead compounds. Even the lead oxides that are commonly used in lead batteries are sometimes sold in small quantities for other applications, like for pottery. So we need to put in place restrictions on who could sell these products in what quantities and who could buy these products to make sure that they're not going into the wrong uses. And then in the case of India, we need to revise the lead battery handling rules, which were recently revised, but I fear that it's not going to have any impact because the system has not changed at all. What we need is a system where they institute a significant price, a higher level price for taking back used batteries at the retail level. This is the only proven way to get lead batteries back from consumers so that they don't go into the informal sector. It's not that the informal sector is paying too high a price to get these back. It's that they're paying too low a price. And so if all operators, all battery manufacturers agreed to pay a higher amount to take these back, we would be able to starve the informal sector of a supply. And the informal sector could then shift to be collectors rather than those working to melt this down on the side of the road or in somebody's backyard. And then we have to classify these lead-using industries that do exist as extremely hazardous and regulate them accordingly by having location siting rules that don't allow these facilities to operate in residential areas. There also should be minimum size requirements for battery manufacturers and recyclers so that they can afford the environmental controls, the emission controls that are necessary to make these plants reasonably safe. And they have to greatly improve standards for ventilation and for air pollution control technology that are in place in these plants. And of course, this over time will encourage consolidation so that we don't have 700 plants melting down lead batteries in India. And we need to bring that number greatly down to a reasonable number over time. And this is the only way to put in place standards that will minimize emissions from these extremely hazardous industries. So in closing, none of this is rocket science. There are some very simple measures that can be taken to greatly improve the situation. It's going to be a long road to make this, to finalize all of these various things that need to happen. but we need to take a stab and we need to start somewhere. And I think I illustrated some of the places where we could start without delay. So with that, I thank the organizers again for taking this issue and raising the profile of this issue in India and beyond. And thank you for the opportunity.
Thank you, Dr. Gottesfeld. This was a pretty illuminating presentation. When we started work on lead, one of the issues that we faced was that there was a lot of legislation, regulation, but none of it was comprehensive enough, and you've just made that point. So we've had a clinical overview, we've had a regulatory overview, and also what is happening in the field of lead, the way it is being handled in the workplace and beyond. And now we're going to be going over to Dr. Sudha Rajagopalan, who's going to be giving us an epidemiological overview. Sorry, late, long evening here. So with that, I would like to invite you to make your presentation. And if you are turning your presentation, whenever you say next, I think somebody from my team is going to line it up. Thank you very much. Over to you. Dr. Rajagopalan, I think you're on mute. You'll have to unmute yourself.
Sorry, I was taking the... One second, hold on. Can everyone hear me? Okay.
It was better with the microphone on.
Can everyone hear me all right?
Yes, now we can.
Thank you so much. I have just been logged in through multiple devices, so that's why it's a little bit of an echo. But thank you so much, Dr. Rai, for the introduction, and good morning, good afternoon, and good evening to one and all. Today, we are going to go over the role of epidemiology and the role of epidemiological data trends in the prevention of lead poisoning. Next slide, please. So, just a 10,000 foot view of what we're going to be discussing today. I'm just going to go ahead with an introduction, just talk about who we are, what is the need for having a lead poisoning prevention program in Florida, what our objective is, what we are, what's our role here, and what our duties are in preventing lead exposure in children, especially those less than 6 years old. And next, we will also be looking at the role of surveillance, things like what defines a case, why do we need the data, how do we get the data, then the role of lead surveillance, and what are the long-term outcomes of surveillance and monitoring of blood lead levels in children and adults. Next slide, please. So as everyone is already aware, no safe lead level is... I'm sorry, there's just a lot of echo, so I'm just pausing a little bit in between to avoid any glitches in hearing. So no safe blood lead level in children has been identified. Even low lead levels of lead in blood are associated with developmental delays, difficulty in learning, and behavioral issues. And the effects of lead poisoning can be permanent and disabling. And CDC, as recent as in 2022, has coined the term blood lead reference value. And it's 3.5 micrograms per deciliter, and the reference. I apologize. There's a lot of. Sorry, there's a lot of technical glitches here today. Okay.
No worries. It's part of the course. Technology backfires. Please go ahead.
No problem. Thank you for understanding. Anyway, CDC as recent as 2022 uses a blood lead reference value of 3.5 micrograms per deciliter. And this reference level, we no longer use elevated lead levels here in the United States. We use the term blood lead reference value. And this reference level helps identify children with blood lead levels higher than most children's levels. Now, blood lead testing is the most reliable method to evaluate lead in a child or an adult's body. It's the only test every Department of Health in the United States accepts to determine if a child or an adult has been exposed to lead. And healthcare providers can perform a simple blood lead test to see if a child or adult was or may have been exposed to lead. Elevated blood lead levels trigger the next critical steps, that is, what the Department of Health does to investigate and mitigate the source of lead in a child's environment. Next slide, please. So who are we? So what do we do? So we are the lead poisoning prevention program here in the state of Florida, and our main role is to identify, prevent, and treat lead poisoning cases throughout the state. We work closely with county health departments, doctors, and other healthcare providers to achieve this goal. Now, we conduct surveillance and epidemiology. So here we track lead cases in real time. We can identify outbreaks and collect information about locations where people are more likely to get exposed to lead. And the program closely collaborates with its local county health departments, healthcare providers, and environmental health staff to identify cases and manage treatment in people with lead exposure. The collaboration enables us to identify possible sources, provide treatment, and reduce future exposure in the case of a positive blood lead test. And we work with the county health departments and healthcare providers to the exposed and provide problems that may arise as a result. And our main role is to conduct primary prevention. To prevent lead exposure, it is essential to know the common source. Our goal is to inform the public about the harmful effects of lead poisoning, educate them on how to prevent it, and work with them to make the environment a much safer place. Next slide, please. So what's the need for having a lead poisoning prevention program in Florida? Now, we've been here in the state for the longest time. We've been here, the program has been active since the year 1992. And first of all, it's our population. Florida is the third most populated state. We have over 21 million people residing within the state. And with that, we have about 1.3 million children who are less than 6 years old. And we also have over 30,000 refugees, at least in the year 2021, come into the country and seek residency. So over 11% of Florida's children are less than 17 years old and are foreign born. Now, refugees and foreign born children are more likely to get exposed their entry into the United States. So that actually is one of our risk factors and also one of our screening requirements, that children who enter the United States as a refugee are required to be screened for lead within 90 days of entry within 90 days of entry into the United States. And children less than 17 years old are foreign born. And when children are foreign born, they're most likely to have had an exposure from their country of birth. And we have over 336,000 children less than 5 years old living in poverty within the state of Florida. And according to the American Community Survey, which is the United States Census Bureau, we have over 1 million homes that are built pre-1950 within the state of Florida. And as Dr. Gottesfeld mentioned earlier in the presentation, we do have a lot of battery and metal recycling plants that are located in the central and southern parts of the state. And here we have a lot of hotspots where we see a lot of not only occupational cases, but we also see an increased number of take-home lead cases where the parents or the caregivers who work in a lead recycling plant or a battery recycling plant take lead home to their children, wives, and partners, through lead dust, either that is deposited on their clothing, hair, skin, nails, boots, or even their vehicles. And last but not least, we do have secondary sources of lead due to the diverse populations that do come into this country. We do see lead in, as Dr. Bhushan mentioned earlier in his talk, and as Dr. Hugh and Dr. Gottesfeld mentioned earlier, that we do have lead contaminated spices that's resulting from the problem of lead chromate being added to spices, ceremonial powders, and other sources such as decorative paints, where these products are unregulated. And like Dr. Gottesfeld mentioned, the need for regulation to prevent these sources from contaminating children's environments further. So these are the main reasons why we need to screen more children, and why we need to establish a lead poisoning prevention program in Florida. Next slide, please. So what's our objective here? Now, our number one main objective is we look to improve health equity by supporting key strategies. Now, what are those strategies? Number one, primary prevention methods and secondary prevention methods. These are pretty much what we focus on, on how to prevent lead exposure or how to mitigate lead exposure in children who may have already been exposed. So one of the program's key strategy is to conduct primary prevention through targeted population-based policy interventions with a focus on community-based approaches for lead hazard elimination. And through secondary prevention methods, what we do is we ensure that blood lead testing is occurring throughout the state. And if children and adults are getting tested, we ensure that the data are reported to the Department of Health, and we ensure through case management that we improve linkages to recommended services. And at the end of the day, we want to enhance blood lead surveillance to be able to conduct primary and secondary prevention. And in order to do these, our key strategies are we work with healthcare providers, we work with county health departments, labs, hospitals to ensure that happens, and as well as community-based programs that are put in place to help the families, especially the ones of low income, to deal with how to deal and navigate with elevated blood lead levels, and how to bring those lead levels down over time. Next slide, please. So at the headquarters here, that is our state central health office that's located in Tallahassee, our main job is we conduct lead surveillance across the state. Now, we provide program guidance and support to all the county health departments that work with lead poisoning cases and preventing lead exposure in children and adults. We also provide clinical guidance to doctors, especially those who are seeking more information on how to clinically manage elevated blood lead levels, or how to treat elevated blood lead levels in children, especially those less than 6, and what steps they need to take clinically to ensure the blood lead levels go down. We also regularly review our surveillance data, that is the data that is reported to us, to look for, quality issues in order to be able to conduct effective surveillance. And we also provide technical assistance to the communicable disease database, that is an ingrown database which collects all blood lead levels in adults and children, whether they're screened, whether they have elevated blood lead levels or not. It is a database that tracks every single lead test that is done across the state. And, through education and outreach, we also promote lead screening and conduct lead poisoning case management at the local level. Next slide, please. Now, what do the county health departments do? Now, the way we are structured is the data are received to us at the state central office, and the data are dispersed through our ingrown communicable disease database that makes real-time blood lead data available. Now, when we make real-time blood lead data available, it is useful for county health departments who are located throughout the state, that is in 67 counties within the state of Florida, to be able to conduct lead poisoning case investigations. And depending upon the range of blood lead level that they encounter, we work with our local environmental health staff to be able to conduct environmental investigations. Now, what does an environmental investigation entail? We have certified in United States Environmental Protection Agency certified lead risk assessors who basically step into the children's environments such as daycares, schools, or homes or multiple residences where the child attends, plays, resides, to be able to conduct X-ray fluorescence tests on lead-based paint, on multiple surfaces within the household that is suspected to be contaminated with lead dust or lead-based paint, and other surfaces like ceramics, linings within faucets, pipes, frames, windows, doors, and anything that they may come across as a suspected source of exposure. Now, once an environmental investigation is done, the environmental investigator usually produces a report, and the report will usually give the family or the department the next steps on what they need to do, and also a referral to community-based resources such as women and infant care, children's health program, or Center for Medicaid Sources, where these programs come in and they help families navigate through the healthcare system and help them navigate elevated blood lead levels and ensure that these lead levels go down over time. They usually give education assistance on how they can further mitigate these elevated blood lead levels. Now, the department also conducts, that is the county health department individuals also conduct education and outreach. They basically are responsible for informing the public on how to educate them on what sources that they need to avoid to, what may be a part of the child's environment that may be contaminated with lead, such as toys, lead-based paint, sometimes contaminated jewelry, things of that nature, that they always want to make sure that they inform the public and educate them on how to avoid these sources. And at the same time, they're also responsible for providing follow-up lead testing guidance. Now, these guidances are provided by the CDC, so we always look upon the testing timeframes as indicated by the CDC, and we ensure we follow up with those families to get a follow-up lead test done to see if the lead levels in the child have gone down or not. Next slide, please. Now, what defines a case? Within the state of Florida, just like any other state in the US, we measure, we say the blood lead reference value is defined as a blood lead level greater than or equal to 3.5 micrograms per deciliter. And a confirmed case is defined as a blood lead level that is measured at 3.5 micrograms per deciliter or greater. That is measured from a venous specimen or measured from 2 capillary specimens or unknown specimens, or a combination of capillary and unknown specimens taken within 12 weeks of one another. And we also look at suspect cases where a person has supportive laboratory evidence. And what does supportive laboratory evidence mean? It means a blood lead level greater than or equal to 3.5 micrograms per deciliter measured from a single capillary specimen or an unknown specimen. So this is how we define what a case is, and we use this as the reference value to be able to classify the blood lead levels that are reported to the Department of Health as a case or not a case. So anything greater than or equal to 3.5 is defined as a lead poisoning case, and anything less than 3.5 is defined as not a case. Next slide, please. So why do we need this data? What do we do with it? We need data to strengthen lead surveillance programs. We need the lead surveillance data to improve blood lead screening rates. In a couple of slides from now, I will be showing how the lead screening rate within the state of Florida was deeply impacted by the onset of the COVID-19 pandemic. Just like any other state out there, our state was impacted by the onset of the pandemic, and due to the governor's mandated shutdown orders or stay-at-home orders, our lead screening rates took a huge dip, especially in the youngest children aged between 1 and 2 years old. Now, we need this data to identify high-risk populations. And the more data that we have, we are able to improve follow-up services. That is, we need case risk factor data to be able to improve follow-up services, like what services do the child or the family need in order to either reduce the lead level or help the child and the family navigate through the effects of lead poisoning and how to overcome that. Now we need data to conduct effective surveillance. How do we do that? We need accurate and complete blood lead data. We work with commercial labs, healthcare providers, basically any healthcare professional out there who's conducting blood lead testing. We work with them and ensure that they report accurate and complete blood lead data. When I say complete with all demographics, children's information, anything that is needed and essential for conducting effective lead poisoning case management. And we also need data to eliminate disparities within populations, so we are able to define who is at high risk and who is not. Next slide, please.
Dr. Rajagopalan, we've actually hit the 20-minute mark. So
Okay.
Could I request you to wrap it up in the next 2 minutes?
Yes,
Would that
yes,
be
please.
possible?
Okay, I will just move through pretty quick. So how do we get the data? I'm going to just go through the slide pretty quick. We have mandatory reporting requirements. We have statutory laws in place which mandate the reporting of blood lead testing data within the state. Next slide, please. So these, you can see how the surveillance trends from 2019 to 2021. I apologize as the data is a little old since we do not have clearance for showcasing the most recent data. So if you see this, you can see how the lead screening rates have dipped over 2020 and 2021. And at the same time, you can see at the right-hand side how the number of confirmed lead poisoning cases in children less than 6 years old have dipped in 2021, and they rose back up in 2021 once the clinics were open, once the testing resumed, and how the blood lead levels just skyrocketed in children who spent a lot of time indoors. Next slide, please. So this shows by month. Now I'm showing the graph where there has been dips in screening rates within the state of Florida, and just in every other state out there where we saw a huge decrease. In Florida, we saw a whopping 54% decrease of lead screening, especially in children less than 3 years of age, 1 and 2 years old. During this time frame, if you can see how the rates were at 2019, how we dipped in 2020, and in 2021 we tried to come back up, but it was nowhere near in 2019. The reason for that was because of the onset of COVID-19 pandemic. We had the stay-at-home orders. We had that was in April, and then come July, we had a Lead Care 2 recall, which is a testing machine that is responsible for conducting point of care testing in pediatrician offices, daycares, Head Start programs, schools, where lead testing is done for children before the start of the school year or before attending daycare. That due to the pandemic, a lot of these kits were recalled because of erroneous or false positive lead test results. And as a result, testing went down altogether again in July and again, in the month of September and October, because of the recall expansion that happened. Next slide, please. The next 2 slides, you will see similar dips within, the screening rates by month in children less than 6. It's how you see the similar trends during the same months. And in the next slide, you will also see the dip in the lead screening by month in children less than 16 years old. Now, this is our entire population of children that we look at, and we usually divide it by children 1 to 2 years of age, then children less than 6, and all children less than 16. So you see the dips where it all happened and why it happened and what the resulting outcomes were. So next slide, please. So this is what the lead poisoning case data looks like, and this data is from when the department was following a lead poisoning case definition of 5 micrograms or more to define an elevated blood lead level. So you see the numbers from 2019, 2020, and 2021. Now you can see 2020 and 2021 how the numbers of cases of higher blood lead levels greater than 10, greater than 20, you see how these two categories, they show an increase, especially for the 20 and between 20 and 30 during 2020. That was a result of children being cooped up indoors. The children were spending a lot of time in these environments where they were, where they were supposed to be. Children were spending a lot of time in homes that may have had lead-based paint, and you can see how the proportion of cases in that blood lead level range was higher than any other year. Next slide, please. Now, one of the reasons why we do lead surveillance, we have a disproportionate effect on lead poisoning rates by ethnicity. Usually, you have a higher impact on Hispanic populations, as you see in 2021, and non-Hispanic populations in 2019. Now, what we try to do is we want to eliminate these disparities by ethnicity. We want to improve health equity, so everyone out there, whoever is at risk, has the accessibility to get a blood lead test done and case management services by either the department or with their healthcare provider in order to be able to mitigate the blood lead levels. Next slide, please. So, next slide, please. Thank you. So one of the other things that is very useful, when we collect the data, we're able to determine which race is actually most affected by elevated lead levels. So in comparison with Caucasians, African American populations, and other, I will define what other is in a minute, that they are the most affected by elevated lead levels within the state of Florida. And we use this data to be able to hone or conduct tailored case management and services so that these populations are able to get the service they need to mitigate the source of lead exposure and reduce the lead levels. Now, the race other is a broad category for Asians, for Pacific Islanders, so many other races that are culminated under the category other. So we use the data to focus more on races that are heavily affected by lead poisoning. Next slide, please.
Dr. Rajagopalan, you'll have to wrap it up.
Yes, sorry, I apologize. This is the last one. Yes, thank you so much.
Thank you.
So at the end of the day, why do we do all this? We want to ensure health equity. We want to make sure every child out there, especially the ones at high risk, has got accessibility to get a lead test done and to be able to get the services for reducing the blood lead levels and, having basically a good quality life. We want to improve intelligence, especially for those children who have been disproportionately affected by lead. And we want to ensure that we decrease the adverse effects of lead in children by, we want to reduce the healthcare costs that are brought about by having an elevated blood lead level. We also want to increase we increase the number of resources that are available for children and families that are affected by lead, and improve the care coordination for those so that they get in touch with the services and the people they need to be able to mitigate the source of exposure. And one main reason is we want to ensure that we reduce the need for special education, especially bought out by the biological effects caused by elevated lead levels. And we also want to decrease hazards in housing. And at the end of the day, we just want to improve the quality of life in all Floridians, so that lead is pretty much a thing of the past, and doesn't affect the quality of life moving forward. That concludes my presentation, and I will be more than happy to take any questions if there are any. Thank you.
Thank you. I think we've had a series of very interesting conversations, presentations, and they kind of flow from each other. So from one side, if we talk about the clinical overview, and then we end at a community overview, almost all of this makes it for a very interesting and a very case-specific program, which lead requires. I think it's the moment that we need to get lead out of the background story that it keeps on occupying, and get it on the center stage. So keeping with this, we have a lot of questions. And since we have run out of time, what I'm going to do is I'm going to take one question before we wrap up. But I've also got questions on my email from my friends who are interested in getting to know about it, from the Queen's University Belfast and University of York, because both these universities work a lot on lead. So I'm going to take one question from Mr. Shah, who's joined us from Nepal. And after this, with the permission of the panelists, and if it is convenient for you, what we'll do is I'll ask my team to email a question each that they think is important to get the conversation going. And we would try and, if possible for you, and if we could solicit your email answers. So the question that we have, what is the occupational exposure limit for lead in air and biological tolerance limit of lead for workers in US and other countries? I think by other countries, he means countries in Asia. I think this is a question for both Professor Hugh and Dr. Gottesfeld. So either one of you who would want to take it up.
Can you repeat the question, please?
What is the occupational exposure limit for lead in air and biological tolerance limit of lead for workers in US and other countries?
Oh, that's a sensitive question for the US, because that occupational standard is administered by the Occupational Safety and Health Administration. It really has not changed in decades. It reflects a kind of a tension between the occupational and the environmental regulatory environments in the US. Perry, do you want to tackle that?
Sure. First of all, I should say that it is out of date as noted on the federal level, but the headline news is that California recently, in recent months, just updated their occupational lead standard for the first time since the 1970s. So this hopefully will be taken up by other states. Currently, Washington State is working on a similar initiative, and hopefully we'll see changes at the federal level. But the old standard is certainly not what we would call state of the art. It was a 50 micrograms per deciliter in the blood for workers, even though we know that there really is no safe level. And for to make it very simple, for air, it was also 50 micrograms, but this time per cubic meter in the air. Neither of these are health protective. Neither of these were ever designed to be health protective, even at the time they were put in place in the 70s. So today we're looking at much greater reductions that are necessary. Even the lead industry has adopted 20 micrograms per deciliter as their target for their target for lead battery recycling and lead battery manufacturing facilities. And that is the new standard being used now in California. And for the air, that has not something that they have publicly adopted, but we know that the California standard now is going to require air at 10 micrograms per cubic meter.
Thank you. Dr. Rajgopalan, would you also like to comment on it?
I actually do not have anything new to add. Dr. Gottesfeld covered it all.
Right. Okay. All right. So basically, we have a lot of other questions, but we just don't have the time. So would it be convenient if we were to email them to you? Would that be all right?
Yes, that would be fine.
All right. Thank you. So I'll take one person's assent as the entire assent. Thanks. Um, all right. So uh, almost all of the presentations, starting with the keynote address, uh, they kind of set the tone for what we want to do. I remember 6-8 months ago when Dr. Bhushan, in his capacity as the vice chair of Asia, asked me to look into lead poisoning and if there is something that we could do. As an economist, although a health economist by training, I was actually not aware about what lead could do. And the more when I started reading into it, when I started interacting with people who know about lead, I came to realize that it has a huge and a negative impact. Uh, Largely in terms of when we think about lead, it's just the highlight things that we are often told about. But there's a lot of background stuff that we are not even aware about, especially because from knowledge production to knowledge dissemination, it takes far too long. And by the time it becomes legislation, it's already old news in the scientific world. So uh, we wanted to start the process of catalyzing scientific knowledge into public policy foray. And the series of presentations that we had today, from a clinician's overview to an occupational quagmire to dealing with it at the community level, kind of sets the tone for what we need to do when it comes to lead. As Dr. Bhushan said, in India, but also broadly in South Asia, because these are issues that we have to deal with. One of the issues that keeps on coming up is the leaded fuel. Although leaded fuel has been banned in most parts of the world, its impact still is being felt just across the world. So perhaps now with the primer that we've got today, the working paper that my team has worked on and has created, we'll perhaps be able to start a conversation with the policymakers, practitioners, knowledge creators in India. And we hope to continue to reach out to almost everybody who participated in the Colloquia today during the morning session and during the evening session. So with that said, I would like to give a formal thank you to everybody who presented, but also everybody who attended. We have had people attending from Bangladesh, Nepal, the Sri Guru Gobind Singh Tricentenary University in Gurugram, and above all else, to the members of my team who did almost all of the work to pull it off, Shipra, Neethi, and just about everybody else who helped them. So with that said, thank you very much. I have made a lot of notes and I've taken a lot of photographs of your slides. We'll be using your slides and other information that we have received to create a docket for the policymakers in the country. I think we'll be sending an email to that effect, but that's what we want to do. And I hope that's all right with you, but giving due credits to everybody where it's involved. Right. So with that said, it's over to you, Shipra, to formally close it, and Dr. Bhushan.
Um, okay. Um, Thank you all for braving the elements to attend today. I know it's a busy time, so I appreciate you making the effort to be here. I am confident that our discussions today will help shape a stronger policy framework and research agenda for addressing the lead poisoning issue in South Asia. Now, I want to give the mic to Dr. Indu Bhushan if he has to say something. Yeah.
Nothing substantive from my side. I just want to thank all the panelists, and it was really a pleasure listening to all three of you. And I am going back with something that I didn't know earlier from each one of you.
Thank you.
Thank you
Thanks
so
a lot. And hope to see all of you in person or at least virtually again.